but we'll listen in later on. Thank you, Alicia. You started recording. So, I'd like to introduce our presenters. I'm delighted to welcome Anya Evans from North Somerset Council. Joining Anya will be Greg Mills, Lisa Mayer, Chris Longson, and they're going to be talking about WASAM and VEA. Jodie Green and Kieran Owen will be joining us from OneCare, talking about NHS Mail, Proxy Access and DCRM. We've got Paul de la Haye from covering DCRM for Baines. And then we should have Grace Amanda, who's going to be talking about an NHS application project that she's working on. And last but not least, we've got Mark de Bernard Lane, who's going to be covering what good looks like framework with the data security. So without further ado, I'm going to hand the virtual floor to Anya. Okay, Anya, over to you.
Yeah, no worries. Good morning, everyone. So my name is Anya Evans, and I'm the project manager at North Somerset Council. I'm coordinating a few digital projects. Could we put the presentation on, Karen? Lovely, thank you. And today we're going to discuss, I'm going to discuss the VEA project, which is delivered by Anthropos and Access Your Care for the first 15 minutes or so. And then I'm going to talk about the WASAM box. And we are actually joined by the WASAM champion today, Susan. So if you have any questions directly to her on a peer level, as she's representing one of the care homes in North Somerset, she's here to answer any of your queries. Okay, next slide. Okay, so just a bit of a background. This is an ICB funding, so NHS funded project. We've received money to purchase 1,000 devices. So the idea is that we'll be able to support 500 users. The project is split between the software company that manages the program, so that's Anthropos, an Anthropos platform, and the centralized monitoring. So local support hub delivered by Access Your Care and based in Weston-super-Mare. I just wanted to mention that both the projects that I'm going to be talking about today cover North Somerset and South Gloucestershire areas. With Bristol, but it's delivered by a different team. So if you're based in those areas, I'll have to just signpost you somewhere else. And for the VEA project, we are particularly interested in extra care settings, but we still have some devices left to distribute in care home settings. So currently we have one home that is live, and that's in South Gloucestershire Council. We are waiting to go live imminently in North Somerset, in quite a big care home, and we have actually not 6, 7 homes now pending installations. I would like to mention the funding. So centralized monitoring, just because of the way that the project was planned, is currently funded until the end of July 2025, and the platform is going to be funded for a year from the activation point. And the cost of the pilot is £37 per resident, so per room. And that's regardless of the number of devices that may be needed in this space. And I'm going to hand over to Greg.
Hi everyone, I'm the Business Development Director at Anthropos. I'm just going to do a quick presentation on what we do and how we do it. So if you could let me know when you can see my slides, please.
Yep, they're coming up.
Okay, we can see that?
Yes.
Okay, so Anthropos, we're not actually a hardware manufacturer, we're a software platform provider and specialist technology partner. The platform's been specifically designed so it has the flexibility and the ability to integrate with a wide range of devices and data sets. Essentially, we provide a future-proof platform with the integrative ability to assist companies navigating fast-moving tech landscapes. So how does Anthropos Detect support better care? We utilise 4D radar technology installed into the care homes, allowing quicker detection of falls. That's obviously the VIR sensors. Essentially, Anthropos Detect's system-connected platform allows you to utilise proactive and preventative strategies to mitigate falls. So it enables much faster responses to falls, preventing long lies and ambulance call-outs. It also reduces or mitigates 24/7 supervision of residents, potentially reducing night checks, enabling deeper personalisations of care plans. When we're speaking to care homes, the guys are sometimes doing 2-hour checks, 1-hour checks, 30-minute checks, even sometimes 15-minute checks, depending on the severity of the condition of the resident. What we found is with a rich holistic view on an individual's behaviour, it's actually possible to tactically deploy staff much more effectively, releasing time to care. So, how does the connected platform work? That's quite a basic diagram of what's going on. The VIR sensors will push the data to the Anthropos platform, whereby Anthropos will aggregate the data together and push it out to the handsets, dashboard, and the call center. Let's say an alert goes to the carer's handset, they would then deal with that accordingly. But I'll run through exactly how that works in a couple of slides' time. Access Your Care will then manage the dashboard, actual insights, and push out the relevant information to the care managers. Anthropos looks at 4 key areas of a resident's life: environment, behaviour, wellbeing and safety, which enables us to build a more definitive, complete picture of a person's behaviour whilst they're in their home. So this on the left here, we can see a picture of the VIR sensor. We put a...
I've also got one here if you want to see.
Yep. Yep. So as you can see, it looks pretty much like the smoke detector. We've actually put a smoke detector in that picture for scale and perspective. There's no cameras, excuse me, no cameras, no audibles, and no engagement with the device whatsoever from residents. So they don't have to charge anything or press any buttons. And this has basically been designed to protect their privacy and dignity. What we can see on the right is a point cloud representation of a person. It's the VIR device scans and looks for bodies of water in a room. So there on the right, you can see that person's upright. The red dot indicates their centre of gravity. So the Anthropos system, we will know with the XYZ coordinates around that room where that person is and their position. So they could be standing, sitting, lying down on the floor. As soon as we see a height transition from this position on the right there to the floor, or we identify a horizontal body of water on the floor, the device then automatically goes into a cascade of events. Firstly, it starts increasing the time to scan in the room for the first 5 seconds. What it's doing here, it's validating that someone has had a fall. Secondly, the second stage, 45-second period, where we create an audible alarm as well as a white LED flashing light. This is to let the resident know that help is on the way. This can be silenced for sensitive residents, but I mean, really, it sounds like the old Casio alarm clock, so it's not too intrusive. In the instance where a cleaner came into the room and so was doing some cleaning under the bed, this would trigger off the alerts. But what the cleaner would have to do is then stand up and then go back down to doing what she's doing. This would deactivate all alarms and alerts. This basically stops false alarms from unusual activity in the room. On the chance that the person is still on the floor after 95 seconds, an alert will then be sent out in the previous way to all handsets and dashboards. Okay. So the Carer app, from a carer's perspective, the system's been designed to be extremely light on the touch from an IT perspective. Carers would have their handsets already with the Anthropos app uploaded onto it. At the beginning of their shift, they'd log into the Anthropos platform with their username and password. This is so we know who has taken the actions in the database and throughout the shift. A notification will pop up on the screen saying a fall has been detected. You would click onto the notification on the home screen and it will take you through to the alert, and then you can click the blue acknowledge button. Once clicked, anyone else looking in on the or clicks on that alert will see that it's been acknowledged by the carer, so no one else responds. The carer would then go and tend to the resident, making sure that person's safe and well, clicks back into the system, into the alert, and then would say what they found and what they've had to do. So, for example, Barbara's had a fall, she's fallen out of her chair, we've gone into the room, we've got Barbara back into the chair, she's safe, unharmed, and then you click save and go on about your day. All of the intel goes back into the dashboard. This is so that the care management team can review and report on it over time or in due course. If an alert goes out to all the handsets and no carer responds, we can do an escalation period where, for example, 15 minutes, if no one has responded, a message can be sent to the care managers by SMS and or email. It also gets notified to someone on the dashboard. So after 15 minutes, Lisa and the team would pick this up and contact you accordingly. So there's 4 different ways that we provide intelligence. Alerts, that's something that is wrong that we need to that needs immediate action. We've gone through that. The actual insights, something that needs revisiting over time, not immediate. So, for example, if the system has picked up that a resident has had increased bathroom activity over the course of the last few days, that might well be an indication of a UTI. So we can go in there and make sure that everything's okay with the residents. Dashboard and reports, we've been over that, and then client activity graphs. So where does the return on investment come from? Obviously reduced falls, ambulance call-outs and hospital admissions, better understanding of residents, improving care options, releasing staff capacity, giving back time to care, and then reducing spend on legacy equipment. Okay, well, I hope that was clear. Has anyone got any questions?
There aren't any questions in the chat, and I can't see anybody has got any. Oh, there's a hand up, Paul.
How are they powered?
So they're powered. It's like a light switch that goes into the ceiling, so it's powered by the electricity.
So you have to get an electrical feed from the lighting circuit.
That's correct.
But usually that's a switched feed that's at the light. If it's have you found that's caused you issues trying to get power to them?
Not in this instance, but I would have to check with my CTO on the details of that question. Apologies.
Okay. Sorry.
We have installed in a care home in North Somerset, going through the lights. The installs are done by electricians and qualified installers, and there's been no issues at the care home that we've used that route.
In several projects I've worked on, there hasn't been any issues from what you described.
Alicia, you got your hand up?
Yeah, I was just going to ask. So, what would happen if there was a power cut? Is there a backup battery installed?
I believe there's a backup battery installed. Yeah.
And in the event of power failure or Wi-Fi, because they do connect to the Wi-Fi as well, then the home would have to revert to processes and procedures prior to the devices being installed for falls.
Yeah.
Can I ask?
We recommend that the off chance there's a power cut, you have a sort of plan B in place there.
So would this system actually alert you if it say had stopped? If say the staff in the home are relying on being told what's happening within the room. If there was a failure of the machine, is there some way or an alarm or something that would alert the staff?
Do you want to answer this one, Greg, or?
Yeah, please. No, it's fine. You can answer that if you want.
Oh, sorry. So if a device goes offline, we get a pop-up on our dashboard which we monitor 24 hours a day, and then we'll notify the home that there's been an issue, and we raise a ticket with Anthropos, who will then investigate to see what's gone on with the device.
Okay, that's good. Since using the system, what benefits have you identified?
Well, from the last slide I went through are the fundamental benefits. Obviously, getting a rich, holistic view on the residents' behaviour, it enables you guys to manage the staff a lot better, and indeed manage the residents' care a lot better. So they're the fundamental benefits.
Jodie, you got your hand up.
Yeah, is this only for kind of care home residential homes, or could it go out to like this independent living, supported living, or personal, people's homes?
I can answer this one, if that's okay.
Yes.
Only from the perspective of the project and what we're funding. So it is a long-term plan, but we want to try it out in extra care settings. So we are looking at extra care providers currently, as well as residential settings as well.
But without the funding, could somebody pay for this themselves to have, or could so say if you wanted it for an elderly relative, is this something you could fund for them to have yourselves?
The Anthropos Detect system is business to business, but they do a product, Anthropos Pro, which is something that goes in kettles and the doors into residents. That'd be more, and that's bought via Liberty Life.
Cool, thank you.
That's great. Okay, thank you for that. Anya, do you wish to continue? You're on mute, Anya.
Sorry. Yes, that would be great. I think I can present, actually. I think I sussed it now. That's okay. Bear with me a second.
Whoever's sharing already may have to stop sharing so that can happen.
Greg's sharing at the moment.
But can you see the slides?
Yes, we can.
Yep.
Okay, lovely. Sorry, I'm just going to open those ones. Okay, so we're going to move on to the Wazan, the Blue Box project, which is delivered by Solcom. So again, we're covering North Somerset and South Gloucestershire, but many boxes were distributed to Bristol as well. We've had funding for 90 boxes for a 12-month pilot, which commenced in July 2023. The project is currently funded until May 2025. And post-pilot cost is £400 per year for the usage of the software. The idea behind it was, but I let Chris explain it much better than me, is to collect the NEWS2 scores of the residents. And what we have noticed is that it works particularly well in care homes where, on different settings, because we are quite open to try out in different sites where staff doesn't have clinical training. And we actually have Susan McPadden from one of the care homes that is using Wazan currently, and they're enjoying the technology, so they're available for questions as well. I've mentioned before on the peer level. I'll let Chris take it from here.
Thanks, Anya. Morning, everybody. My name's Chris Longson. I'm the account manager for Wazan. We're a digital health company based on the Isle of Wight, and we provide remote monitoring solution through our Blue Box Wazan system. The next slide is just a Wazan overview, where you can just see we've got a customizable dashboard. We are currently working with NHS virtual wards, care homes, remote health checks. We also do some activity monitoring. We are doing this in care homes as well as local government and councils, as well as the blue box. If you wanted to see some activity monitoring with your residents in care homes, we have got extra equipment we can add to our standard blue box, like PRI sensors, falls detectors, which can also report back to our dashboard on the same dashboard as your blue box. Thank you. This just shows our interoperability with other systems. So our Wazan dashboard is integrated with a lot of NHS systems, which we can post our results into. Not too relevant for care homes, but when a lot of care homes have a good relationship with their GP, our dashboard is a web-based dashboard. So anybody can log into it with a username and password. So typically we'll have a care home with a blue box with their residents on. The GP can also see these residents, excuse me. So if there's any concern, the GP can look at these residents and post their observations into System 1, Rio, Nourish, whatever kind of system the care home or GP is using, we can integrate it and post it into that system as well. Thank you. The next bit is just compliance. We're not spending too much time on this one, just to show that we are on our mandatory data system standards and we exceed all those standards. So the blue box, this is our blue box, what each care home will have. The aim of the blue box is to improve patient care through regular News 2 score checks, giving baselines, from which any potential declines can be assessed. Our system doing this has been proven to reduce hospital admissions, 999 calls, ambulance conveyances, and unplanned GP visits. What we find before having the blue box with a lot of care homes is that any concerns raised about from the staff raised about a patient's health, they might call an ambulance out even if their measurements were normal for the patients. So what the blue box can do is over a period of time, you can build up a baseline for that particular residence, which builds up graphs and trends on our dashboard. So it's all about detecting signs of early deterioration. So you wouldn't just go in and see a resident and think, oh, Mary looks unwell, let's ring an ambulance. With this kit, the staff who probably aren't clinically trained or to a certain level, using this kit would give them the confidence and the evidence to say, oh, I've done a set of readings on Mary today. She's now presented a News 2 score of 5. So we've got some concerns. And then you've got the evidence to back that up. If you do raise that with a 111 call or a GP call or a GP visit, you've got some evidence backed up to say, we've done our observations. These are our observations. They're slightly above or below Mary's normal, what we think is our normal, and we've got a concern then. This would be what's presented on the tablet. So in the blue box, sorry, can we just go back a slide, please, Anya? Sorry. So, yeah, in the blue box, you can see there each box contains equipment for monitoring residents' vital signs, including temperature, BP, blood oxygen levels, consciousness, and respiratory rates. And this box can be used for multiple residents, not just one box for one person. You can have 100 plus residents on one box if you wanted to. It connects to Wi-Fi, or you can use a SIM card if you've not got very good Wi-Fi connection, which a lot of care homes don't have. The equipment you can see in the blue box is all Bluetooth connected to the tablet. So it's just a simple case of very easy to use. You would do your observations on your residents. The tablet then speaks out. So it would then say your BP today is 120/80, your temperature is 36, etc. Then that will post the results onto the dashboard for your care home manager, GP, whoever you've got access to see that would see those results on the dashboard then. Thanks, Anya. This would be the view of the tablet for your carer who's going around the residence. So on the iPad, they would log in their iPad. You've got your caseload built of your residents, number of residents. They'd see each resident, and then they'd simply just click on one resident. And then you've got next slide, please. Presents this screen to them, very simple. They go through all their observations then. What this does is put your BP, your blood oxygen, your pulse, your temperature, and your respiration rate into this tablet simply by Bluetooth. You then have to do 3 simple checks of the buttons to present a News 2 score. So your level of consciousness, any specific clinical concern, and does the patient breathe air or supplement oxygen? This presents a News 2 score automatically, which then gives your carer the confidence and the evidence to say they've got concern or no, everything's okay. you can show the next one. This is the NEWS2 score, which is the National Early Warning score, which is nationally recognised by the NHS. This will present a chart. If you wish to see this, this can be saved as a PDF if you need to print it out and present to anybody, like a ambulance visit or a GP, or you can save an email to somebody as well. And again, if you've got a good relationship with the care with the GP, they can see all this information as well. So if you've done a set of observations on a resident and you've got a concern, you could ring your GP. He can log into Wizan if he's not already got it open on his system and see all this information within seconds of you doing a reading. The beauty about this is then the GP could then say to you, or a 111, whoever you want to raise your concern to, they could ask you to do another set of observations, which you can do over the phone. So they can see it within seconds again, or half an hour afterwards to see if their observation have changed. With the tablet, you could then, even from the dashboard, you could do a one-to-one video call. So all they simply need to do is select start call on the dashboard, and then you've got face on with a residency care home. So you can actually physically see if your resident pale, clammy, the chest, rise and fall of the chest. So you can do a video call as well if you wanted to for extra benefit. This would be your dashboard view. Usually this is something that your care home manager, deputy manager, whoever you wanted to give access to can see this. These are all test patients, so it's not any private data. This would be your list of patients with your names on the side. They're all connected to the spine with your NHS number, date of birth, and then it presents their readings in this kind of fashion, so you can see what their readings have been, what's been taken. If you've got their observations set, parameters set, sorry, you can set their parameters so you know what each individual resident's normal is. Once you've done your observations, if they go above or below their normal, we'd present it in a RAG matrix, so a red, amber, green. It would then present an alarm on the dashboard if you wanted it to do that, and send an email to anybody you wanted to say, today Mary's observations are above their normal and it's raised a red. So you can proactively look at that rather than just going around and just doing your observations. This is just a weekly view. So as I said earlier, the more readings you do, you tend to pick up a trend of what the normal is for that resident. So somebody's normal might be higher than everybody else, but that is their normal. It depends on each care home. Some do weekly observations, some fortnightly, some monthly. Obviously, everyone's busy in the care home, so it depends how you want to set that up. The more you do, you get a better idea of the baseline. You can see the trends and graphs of each resident. And like I said at the start, about detecting early signs of deteriorating. So you're not just going in and somebody's declining and you might get a water infection, then your first call would be to get an ambulance. With this, what we've seen is from the evaluations we've had back, it does stop ambulance visits and admissions into hospital. Thank you. This is just a dashboard view. You can do these different kind of views on dashboards you can present. And as I've just said, you can see like charts of each patient's BP, blood oxygen, pulse, whatever piece of equipment on the box. The standard is what I showed you earlier, but you could also add scales. We also do bloods, lipids, glucose, cholesterol checks, Falls devices, assessments. If you wanted to delve into things like that, this could all be added to the dashboard as well. And you can see it in different views to show different trends and signs of deterioration on the charts and notes as well. And if you have got any concerns, the person who does the readings or even the manager can add notes to each resident. So when you're changing staff, you could see yesterday's notes just to see if you've got any particular concerns, so you know where you are with each resident in your care home. You can also run reports of the dashboard if you're interested. This could show you how many residents you've got on, how many observations you've done, what kind of observations you've done. If you're interested in doing some reports, there's many different scenarios, reports we can pull out for the system as well. Thank you, and that's my quick overview of our blue box, what's in your care homes. Thank you.
That was really good. Anya, do you wish to finish off?
Yeah, just to say that if anybody would be interested in either Wazan or Veya, you can contact me on the either on the number on the slide or my email address. And I just wanted to mention that Suzanne is a champion here for Wazan. So if anybody has questions, particularly about Wazan, Maybe we can spend a few minutes on that. But I will finish this slide. Just to say, there are some requirements to participate in either of the projects. So obviously the willingness to trial the technology for the care home and the staff. We would require some evaluation, but it's not very often, and we try for it not to be painful. And obviously because of the nature of both of those technologies, we would require the care home to have access to Wi-Fi and be on the way to digital literacy. And as I mentioned before, we've got the area eligibility too, which is South Gloucestershire and North Somerset.
Okay, thank you. Does anybody have any questions with regard to the WASAM? Kieran Morris, you got your hand up?
Yeah, hiya. I was just wondering about the funding of all of this, really, because to me it seems like it should be the ICS that should be funding it, because both projects go so well to avoid hospital admissions and easier discharge, etc. So I'm just wondering if those conversations are sort of in place with ICSs about it, because it's quite health focused, isn't it?
Yeah, so people in my team are working on hospital discharge projects, which is slightly separate, but is still delivered by the tech team within the council. If that answers your question.
Yeah, no, it was more about the funding of it, but it's something I can raise tomorrow at the People Board, actually, because I'm doing quite a lot around sort of hospital attendance as well. So I'll raise it there. Thank you.
Thank you.
I've got a question with regard to once you've installed, say for example, you've installed the blue box. What follow up, what background, what support do organisations receive? Is it installed and then the home is just left to sort of run it, or is there sort of a support desk that they can go to?
Yeah, so when you get your kit delivered, what we'll do then is give you a link to contact our support and training team, and we'll give you a training session. So this is usually over Teams, takes about 30 minutes, and we'll do as many training sessions as you want. There's no charge for any training or support from us, so you can train individuals, train teams, different staff coming in. So we do a Teams training, show you how to use the kit. Any issues or any further support you need from that, we're just a phone call or an email to our support team, and we'll give you as much help as we can to use the kit.
That's good to hear, because I think, it's very well sort of landing it, but it's embedding it as well, which is key in social care. Paul de la Haye, you had your hand up. Are you still? Yeah, you still have.
Yeah, it was really good, really interesting stuff about the WISAN. Obviously the kit that's in there is going to wear out, is going to break, malfunction. What's the sort of support for that going forwards? Do you have to buy replacement bits of kit, or is that included in the annual/monthly rental?
Yeah, so the kits, different care homes have different plans. We usually advise to renew your kit after 3 years, and a lot of people do like a rolling replacement. To answer your question, the £400 what Anya's quoted is the software license, and it's funded by different streams. Some like this one, it would be local council. A lot is what Karen was saying before. ICS, ICBs fund the kits for the care home. So the Isle of Wight, where I am, we're in 85 care homes here, funded by the NHS. Because as you can see from the presentation, you save by care homes having this kit, they're saving the NHS thousands of pounds, not having them as hospital admissions. So quite rightly, the NHS do fund the care homes. If I use Lincolnshire for an example, Lincolnshire Care Organisation have their own tech team which fund the care homes. So if there's any kit replacement, that would go through Linker, and they will replace the kit for the care home. And there's not many care homes. There are a few, but there's not many care homes would replace the kit themselves. So we have had some contracts where the ICS or for whatever reason have stopped funding the Blue Box project, and some care homes have took the Blue Box on themselves, individuals, so paid for the license themselves. And if that's the scenario, then if any kit did fail outside of warranty, yes, they would be expected to replace that kit themselves, which is usually funded by local government councils or NHSs.
Lovely, thank you. Suzanne,
Thank
you've
you.
got your hand up.
Hi, I just thought I'd throw in the reality behind how it's working in the home, just so that people have a sort of bigger picture of the sort of handover scenario. So the training, I have to say, is second to none. Whenever we needed extra support, they've jumped in. I mean, obviously you have staff changeovers, you want them all trained to use the system. There is always, weirdly and amazingly, someone there to help you through that, which is just fantastic. This setup was more challenging, but that was more to do with us on the techie side, and again us transferring it in a much easier route using support from our techie team rather than there was lots of support, but we just needed to sort our own side out. One of the things I will say, it's a lifesaver. We call it our little blue nurse rather than the Wizan. To have a system like that in the home that we can know that we know it's reading the news to train all your staff at care level without a nurse in the building to understand it is very difficult, but the reading's there, the GP can log into it. It gives us a nurse in the building because they understand that reading. The GP is more than happy to work with us and not send residents into hospital, which that's our last wish with dementia. The way it is now, the last thing we want is for them to be admitted. So we do all we can and we feel safe. So there's less safeguardings. They say, why didn't you pick up that? Well, we have. we've got on our little blue nurse and it works for us. And I would really ambassador it to so many homes to help, especially residential.
That sounds absolutely brilliant. It's good to hear. It's good to hear somebody who's actually using the system, and I guess Chris and Greg can talk all they like about their product, but actually using it is key, isn't it?
Absolutely. I think again, just to mention, sorry, quickly, the add-ons. So we add on like an extra large sleeve for the arm. We've got little bits. The other thing is you always got it in one place and it's always charged. It's literally where our defib is. And I mean, the amount of times back along, we've got no batteries in your BP machine. You've got, things aren't working and you can't find things, but this all goes back in the box, which is fantastic. I know they've made a much smaller one, which we would like because the original one is very big, but it is fantastic for that purpose. But there is a cost to adding it to your care plan, so that must be noted. And I think that we weren't aware of that, and that's just something that maybe should be added in with the sales side, because it's an extra £15 a month for PCS to take it on, to add it into the system, which is vital because we want it in where the care plans are per home. And so you just need to make sure with all these add-ons, we have got so many add-ons, it's getting ridiculous, because we want to be as techie and have that immediate access, but we've just got to know that we can do it within our financial remit, really.
That's absolutely true. Cost is key, isn't it?
Absolutely.
Thank you, everybody, for your time. It's time now to move on to Jodie and Kieran Owen. I think Kieran's on as well. Jodie, do you want me to share
Yeah,
yours?
if you could share them, that would be great.
I think Annie, you might have to stop sharing the original screen.
Can you see my screen now, One Care?
No, not
Not
yet.
yet.
Oh. Okay, try again.
I'll start whilst you're trying to figure that out. So I work for One Care. We are a GP federation that covers BNSSG, which essentially means we provide business supports to general practice. Out of that, we are a project team that have been set up to help care homes become what we call more digitally mature. So historically, care homes are very, very paper-based, and that's open to a lot of errors, GDPR, like it's not very great data security, things like that. So our team has been brought in to support care homes to become more digitally aware.
Can you see the screen?
So, yeah, we
Is
can
that okay
see
now?
it now. Yeah.
Just open it up for you. There you go. Okay.
Okay. So the idea is to improve communication with staff handovers to the residents, family, friends, and health professionals. So next slide. So on the team, there is currently 4 of us. So there's me, Jodie, there's Eric, Zana, and Kieran, who are digital support officers. So predominantly Eric, Zana, and Kieran are the ones that will contact the care homes and go out and provide the support now. Next slide. So just going over who One Care are, like I said, we're one of the largest GP federations in England, so representing and supporting 66 general practice partnerships, offering business support, direct support services to practices, primary care networks, PCNs, localities, etc. We use our expertise in learning to constantly improve, move forward and support. So yeah, next slide. Okay, so what is the project? So we support care homes with NHS Mail, ordering medication online. So we call that proxy and it's via patient access, storing resident records, so which is the DSCR, which Kieran will talk about, and then communicating better with the GPs or health professionals in general. So next slide. Okay, so NHS Mail. So NHS Mail is the National Secure Collaboration Service for Healthcare in England. Basically, in a nutshell, it's fully secure and encrypted, meaning that you can share patient identifiable information from the care homes to the GP practices or other health professionals and back again without the risk of that being intercepted anywhere. So how we support with that is, sorry, to take a step back, to have NHS Mail or to have any of the services that we support with, you've got to have DSPT first of all. So if any of our care homes don't have that, we get in contact with Karen and she supports on that side of it, and then they come back to us and we do the NHS Mail. So how we support with NHS Mail is we basically set it up for them. So a lot of care homes will have a shared mailbox that they don't know about, or they have a shared mailbox that they don't have access to, or they have individual mailboxes that they don't know about. So what we do is we will go in and we will set up their individual NHS Mail accounts. We will then set up a shared mailbox. So by that, it's not a email account as such, it's a secure mailbox that anybody within that care home who has NHS Mail can access. So it's a really good tool for anything that goes to any health professionals to come back into that shared mailbox. It is completely secure. It just stops errors. So we would set up all of that, and we do like password resets, unlock accounts, and just support in general with setting that up. It's quite a lengthy process, and we're aware that care homes are really, really busy. So a lot of the times they just don't do this because we're kind of selling them something that they don't need, but it's good practice for them to have. So across BNSSG so far, there's 51% of the homes we've supported now have NHS Mail. So at the moment, there's 264 CQC registered care homes. So we're doing pretty well. Next slide. Okay, so the next step is proxy access. So proxy access is giving authority to somebody else to order your medication for you. It's basically a different way of care homes ordering medication. So previously they would complete the MAR charts, that would go to the GP and then go to the pharmacy. It was open to a lot of medication error, ordering error. over-ordering, under-ordering, medications going missing, incorrect medications being ordered. So with patient access or proxy access, we use the patient access system, which I'm sure probably a lot of you use anyway to maybe order your own medication. It works very similar. The care home staff have a login, so they've got to have an NHS email account to be able to use proxy access. So they will have a login, they will go into patient access, they'll have access to their resident medication orders only. So they can't see, at the moment, there's not an option for them to see the whole history, medical history. They can purely see the medication ordering. That is linked to the GP system EMIS. So it should be correct to what is on their records, what they should be having. The point of it is it will reduce errors because they will literally select the medication that's on the list. It goes straight to the GP authorises it, so it saves the GP having to manually input it into EMIS, so again reduces an error. And then that will then, once the GP authorises it, it goes electronically to the pharmacy and again stops error. So there's kind of a 3-step process that will reduce errors constantly. So what we do is we will provide all the paperwork to the care home. So there's a data sharing agreement and what we call a proxy user paperwork. So we provide all of that. We support the practice by adding those users onto the EMIS system, which on average takes around 8 hours per care home. So we're saving general practice financially for that because we're providing that support to them. We then go out and provide training on how to use patient access, and we continue to provide training for them as they need it. We find that obviously in a lot of care homes there's quite a big staff turnover, so it's something that we're constantly kind of business as usual, helping set up, helping them to order medication, train and things. So next slide. I'm conscious I've got 10 minutes, that's okay. So Kieran is going to talk to you more about digital social care records.
Thank you, Jodie. I'll get through this as quick as I can.
I'm going on mute.
Am I? Am I on mute?
No, I said I am.
Oh, sorry, that's okay. We also handle and support funding for digital social care record systems in the BNSSG. For anyone who doesn't know what this is, it's an online system used to manage and store resident information. And this will obviously replace paper hopefully replace paper and make the system more seamless. They are designed to make storing and retrieving information for care workers and managers easier by saving time spent on the administration and reporting. So the funding for this, which we handle, and I handle for the ICB, the funding is £140 per bed/client with a maximum cap of 100 beds. Obviously, there'll be information packages containing this for anyone who is interested, but essentially it is a one-time payment to help subsidise the setup costs, which is the most lengthy costs in a DSCR. The way our support consists in this is by sending information packages in stage 1 to any interested provider. We also offer support such as Teams calls to run through the requirements where they should look for information such as the assured suppliers, how to get through, say, who to contact for DSBT such as Karen, and what the MOU needs to be done and what the requirements are overall. So once we've sent them the requirements for everything, we then have to liaise with the care setting to ensure we get those contracts back, they're completed properly, we get the banking details ready off of them, and just be available for any questions they may have on timing, stuff like that. And then the stage 3 is organising payments and communicating with North Somerset finance team who handle the actual funding itself. So we don't hold the money. I'm sort of the middleman who brings it all together, and we go on from that. We then allocate the correct funding depending on the care setting. So obviously, if you have 100 beds, you'll get 14,000 / clients, obviously for domiciliary care. But yeah, that's how we organise it. And obviously, I'll have more information on this. I know we're short for time, so I'll leave my email in the chat for anyone who's interested. And the funding is sort of coming to an end. We want everyone to have the steps completed by, around the 1st of December. Obviously, to implement it, you have till March the 1st, and obviously more information beyond this when people will want. But yeah, that's everything. Thanks.
Thank you.
That's our whistle stop tour.
Well, you've done very well for time, actually, so you do have a little bit more time. If anybody does have any questions, now's your time to ask them, and Jodie and Kieran can answer. I should say, Kieran, you're covering Bristol, North Somerset, South Gloucestershire.
Yes.
On the DCRM. Paul Delahaye is in the background. Paul, you're there, aren't you? Do you want to pick
Hi,
up?
Kieran.
Hi, Paul.
Well, thank you, Kieran. You pretty much sort of ran through exactly what I do. You do it in BNSSG. I do it in BSW, which is Baines, Swindon and Wiltshire. Care and Support West looks after our Baines section for DSPT. So if I get a provider that doesn't have their DSPT done, then I pass them on to Karen and she gets them up to standards met. That is one of our criteria to qualify for the funding. You do have to be at standards met for your DSPT. Some people think it's a bit of a mountain to climb, but once they actually get their head into it, it isn't as bad as it seems. There's all sorts of templates there now, which make life a lot easier. So our system is very, very similar to Kieran's. The only maybe slight tweak is once somebody has completed an application form for us, I then submit it up to the ICB and get that sort of rubber stamped by them that they're happy with all the criteria that we've put together on the form. And then I issue the care provider with a grant fund approval certificate, which, as I say to them, it's basically your check. And they then have to become a supplier to the ICB, and they then submit an invoice to the ICB supported by their grant fund approval certificate. And they also have to have proof that they are actually implementing the system. So they have to have an invoice from their software supplier. And as Kieran said, the setup is usually the biggest cost, and the funding goes towards their first year. £140 if they negotiate well with the software suppliers puts a pretty big dent in their first year's worth of costs. I think to date I've only had 1 or 2 suppliers that have actually come in under the £140 per head budget. Most of them are over by the time they've bought some digital kit to get it all working. We try and make it as straightforward as possible. And if there is anybody on the call who doesn't have a DSCR yet and you're in the Baines area, I too will put my email address and contact details in the chat. Karen very kindly said she will make sure that is circulated with the slides. And as Kieran says, the clock is ticking. Wrong hand, that way. Anyway, the clock is ticking. You've basically got to get your info into us, applications done. Latest is like the 10th of December for me. If the application lands on my desk before the 10th of December, then yes, you will get your grant fund approval certificate before Christmas. But you do have to have it rolled out by March. So the sooner you get on with it, the better. Okay, that's about it.
Thank you. Well, we're doing well for time, so well done, everybody. Does anybody have any questions before we move on to Grace? No, there's nobody raising their hand. Okay, all right. So Grace, are you here? You're here,
are you? Take up some of that time for you. Hi everyone. My name's Grace Manda. I am a project manager at OneCare, the GP Federation. And I recognise some of your faces because I used to work on the care home project with Jodie and Kieran. So now I'm working on a project focused on increasing the usage of the NHS app in BNSSG. So I'm just about to pop my classic message in the chat, which is, have you got the app and have you got your notifications turned on? So I guess, first of all, I just wanted to kind of get a bit engaged and find out which of you guys actually have the app and which of you have your notifications on. So if you have the app, can you put your hand up, please? or an emoji. Yep, Okay, so I reckon about 50% of you have. And what about how many of you have your notifications turned on? Ooh, bit less with the notifications. Okay, so I'll explain to you the sort of differences between the two today. I've got a presentation here. Karen, if you wouldn't mind, I'll just share my one because I've just added one more slide to it, which explains the differences between patient access and the NHS app.
Sorry, did you say you want to share? You should carry on.
Yeah, I'm just going to share one that I've got. Yeah, just because I've popped in just one more slide.
No problem.
I hope that it'll be a bit more helpful. So the aim of the project is to increase uptake and usage of the app, and that includes bridging the gap of digital exclusion and improving the message journey as well. So obviously there's different cohorts within BNSSG who might not necessarily be able to use the app for a number of reasons. So that's why digital exclusion/inclusion is also a focus for this project. So what is the NHS app and why does it matter? So the NHS app is for people aged 13 and over. You can register for the NHS app from your home with just your ID, and you don't need to go into the GP practice. On the NHS app, you can order repeat prescriptions and check their status. Some practices allow you to manage appointments on there. So you can definitely manage and cancel your appointments without sitting on the phone and waiting to get through to someone. In terms of booking, only some of them allow that. You can also view your health record. So it's always in your pocket wherever you go to see any health professional. And you can also view your test results as well, which is sometimes a quicker way of receiving those. Importantly, your GP can message you through the NHS app for free. Because if they send SMS messages, it costs money. And the way that they're able to send you messages through the NHS app is if you've got the app downloaded, you've got your notifications turned on, and you viewed that message within the fallback period, which is usually 4 hours. So I've created some helpful graphics which explains like the benefits to staff and patients. So as a few examples for staff, there's shared decision making, so patients can access their own health records, enabling them to participate in their care. Reduce phone traffic, so for example, if people are cancelling their appointments in the app, if they don't need them anymore, and also if they're viewing their test results in the app instead of calling through to the phone line. And also some people email and call for their repeat prescriptions, but the app allows you to do that through that much more quicker as well. So benefits to patients are quite similar in that they can view their test results. They've always got their medical record in their pocket. It's a more secure way of getting messages because it's more secure to click on links from the GP in the app than it is to click on a link that's been sent to you via SMS. And you can also have access to your family records, etc. So,
Grace, sorry to interrupt you. Susan's got her hand up.
Oh, yeah.
Have you got a question?
Sorry, I can't see.
No. Susan, have you got a question, or is that an old hand? Must be an old hand. Okay, sorry, Grace, carry on.
Yeah, so a question I get quite a lot is what is the difference between patient access and the NHS app, because they are quite similar. They do similar things, but the NHS app does offer more. So patient access differs from the NHS app because patient access allows you to have access to people's records who aren't at your own GP practice, whereas on the NHS app, if you want access to someone else's record, they need to be at your same GP practice, which usually kind of with a mother, father and children, they usually are, but sometimes you find that they're not. So I guess that's a bit of a downfall of the app, but it does have a lot more functionality in that it lets you check the status of the repeat prescription order, not just what order you've made, and that's a development that's come along recently. As I said earlier, GP can message you through the app. They can't message you through patient access. The NHS app offers a more comprehensive view of your medical record because it's directly mirroring what's in your record, so it's often more detailed. And also the NHS app integrates with the Acute Trust patient portals. So a new development is that the Acute Trusts are going to be allowing appointment letters to be in the NHS app instead of being posted through to your door. So we've been through the beginning of this project, we went through a discovery process to understand what the current progress is. In BNSSG, we have 60% of people registered for the NHS app, which is above the national average, which is 56%. But we're trying to get to 75% now. So we've got a big push on getting people to download the app and turn their notifications on as well. So as a bit of a breakdown about that, we've got the total patients in BNSSG, we've got 52% of them with the app, and then 48% without the app. But of those people with the app, only 42% of those have their notifications turned on. So we've got to focus on getting the other 48 to turn the notifications on so that they can receive those messages from their GP and reduce those costs. So for anyone in the room earlier who didn't put their hand up for either app or notifications, I'm trying to urge you to get that downloaded, get your notifications turned on, help the NHS save money. And also at the end of this, I'll explain how we can encourage other people that we're caring for to do that.
Okay. 2 minutes, I'll go in the kitchen.
So the uptake of the NHS app varies significantly by practice. Sorry, I think someone's not on mute. So the uptake of the NHS app varies significantly by practice. We've got the likes of Student Health Service who have got 94.6%, and then we've got another practice who is all the way down at 21.9%. There is different reasons for less downloads. So it could be, we found that it's related to areas of multiple deprivation. We found that it's related to areas with English as a second language, and also practice size has a relation. And I think that's because bigger practices are usually in more affluent areas. So these are the different message types that can be sent through the NHS app. This looks quite confusing, but I'll just explain to you what it is. So only at the moment, single simple messages from GP to patient cannot be sent through the NHS app. They can only send batch messages, and that includes appointment reminders, simple messages, self-book links and questionnaires. They are piloting single simple messages though in London at the moment. So once that goes well, they might be able to introduce that to the app as well, and then it can be a single platform for all messages. There's quite a few barriers to people taking up the NHS app, so I just wanted to give a few examples. People don't feel the need to use it, lack of awareness about it. They don't have the money to buy data or devices, maybe some concerns around data use and security. So to address those, we've partnered with the Good Things Foundation, who basically provide an online map of all the organisations in Bristol who provide free data and free smartphones to people who want to get access to their online services. We're also working with libraries across BNSSG because NHS England have funded them to provide free digital support for people who want to get the NHS app. And within this map that the Good Things Foundation have provided, it shows all the different organisations as well that can provide NHS app support, much like the libraries would. So I've been going out to GP practices and trying to get more downloads, but also take that pressure away from them by sending people out into community if they need one-to-one support, maybe a coffee morning or something like that. So next steps, we're trying to get system partners involved in the NHS app. So at the moment, the acute hospital trusts have paid for the integration between their patient portal and the NHS app, but Serona, the community health providers at AWP have not yet. So we want to organise a system-wide workshop where we can talk about the costs of that, the benefits to people using the app, and what impact it would have. So there's a roadmap available which explains to you all the sort of developments that are happening in the NHS app. I'm just trying to keep an eye on sort of developments that are happening locally, because that's obviously important to us. And, you know, as I say, those digital appointment letters from the acute trust is a really important one coming in. And also the tracking of the prescriptions was quite a good one as well. So for our next steps, we're doing a local comms campaign. So we're going to have resources available that are localised. So it's going to have BNSSG numbers on it. So how many people have downloaded the app, etc. already. We've produced a toolkit, which health providers can use, which has things like this map in it, where you can get the support from the libraries. It's got strategies for increase and uptake. So that's that. we're partnering with a VCSE, and we've been in talks with someone already, but we haven't yet had the proposal confirmed, so I won't say their name yet. But they will be working with us across BNSSG to provide support to digitally excluded cohorts in helping them to get access to their health services online. There's a bit more about the toolkit because it includes things not only about uptake of the app, but also digital inclusion strategies and also best practice for SMS messaging. And that actually brings me nicely on to the end of the presentation. So I hope from that I can encourage a few more of you to download the app and turn your notifications on. In terms of helping people you care for get the app, if it's something you're interested in, I have a one-pager which I've been handing out at flu clinics, which basically has one side really basic instructions for downloading the app. So it takes you down one route, which is you have your ID, you have your camera ready, you take a photo and you set it up from home. And then on the other side, it's got that benefits graphic so that you can be well equipped with how to promote it to the people you care for. So explaining to them what is actually available in the app. So I'm going to pop that one pager in the chat. Happy for any of you to use that for the people that you care for. But other than that, I just wanted to take any questions.
That's great. Thank you, Grace. There's nothing in the chat at the moment. Oh, does anybody have anything? Can't see any hands raised from this side. I've got
in the background. I was sorry.
I was going to
say, while we were talking, Grace, I think of us have been turning on our notifications, so you've had a few more join.
Yeah, so well done, guys. Thank you.
Sorry, Karen.
I was going to say I've got I actually on my phone I've got NHS app and I've also got patient access. It confuses the hell out of me because I know
so people often ask.
Yeah, and because if you go into patient access, it actually takes you to NHS app. So and I remember I had to go to the doctors to actually get them to give me a number, like a registration number, before I could actually register.
Was that for patient access?
I don't know.
Yeah, so patient access, you have to go to your practice to register, whereas the NHS app, you can do it from the comfort of your home. And I always just try and encourage people to just take this one process, which is get your ID, take a photo of it, record your face saying a couple of numbers, and then it will confirm you later on within 24 hours, I think. I
must admit, I'm quite, it was quite a shock to see how much I could read about me on the NHS app.
It sometimes comes with risks, doesn't it? That you get the information before the health professional has provided it to you. Obviously, there is that risk, but it is a direct mirror of your records, so it's going to show you whatever they can see, basically.
Well, I think it's very, very good. And as you say, this is the thing about technology, isn't it? I mean, it's advancing forward all the time. And this is one of the things about this workshop today. I mean, we've learned so much about what technology, what it can do to help us to improve the care that we give to people. I can't see anybody's got a hand up, or there's nothing in the chat at the moment. Alethea, can you see? No. Okay.
I don't think I can add things to the chat. So would you mind if I send it to you, Karen?
Yeah, absolutely. That's fine.
Thank you.
Yeah, we can promote that for you. It will go, if you send it, then when we put it on the Care and Support West members page, it will go. Susan, you've got your hand up. Got a question? But I'll just finish what I was saying. The Care and Support West members page will carry this recording and also any of the slides. And if you want to send anything, we can put it on there as well. So thank you.
Susan, I forgot we're being recorded.
Just from a group sort of point of view, it might be worth putting that out to all the managers locally in North Somerset and all that to be ambassadors to get their staff involved with understanding. A lot of ours are from overseas and they would probably need some hand holding to do that. I'll certainly get behind it, but it's something I haven't really thought about, to be honest, but actually would really help them, I'm sure, with day-to-day connection, because now they've all brought their children over as well. I think it might be worth a bit of a campaign on it.
Yeah,
us
we're
there.
trying to get some translated materials together, and
That would be great.
our VCSE in Inner City is definitely good with that. There are already some resources available online, just not in every language. But the NHS app doesn't come in other languages. It's only the promotional materials that do. So yeah, it's really important for us to get a VCSE rep who's going to help us work with those communities so that they don't feel like they are digitally excluded as we move through this process. And in terms of North Somerset, we've met with the locality leads up there. So yeah, we're already ploughing our way into that area.
That sounds really good. The questions are coming in thick and fast now. Lisa, you're first.
I was just going to say, I'm going to take this away and speak to our communication lead and see if we can get it on our social platforms, etc., because it's a good message to spread and get out
fantastic. Thanks so much.
And Paul Delahaye, you're next.
Yeah, I had downloaded it, turned notifications on ages ago, and I just thought while we're on the call, I'll just have a look. And it had basically signed me out.
Okay.
They said when I've just gone through now and reset it up, I had to go in and put my username, password back in again. It said there'd been changes in the organizational changes. So if you haven't used it in a while, it's worth going back to check in that it's still there.
Yeah.
And the other thing is, if you're a bit like me and you take lots of photographs and you use up most of the storage on your phone, your phone will intelligently look at apps you don't use a great deal and then just bang them back up to the cloud. And so once they're up in the cloud, then the notifications won't work.
I didn't know that. That's interesting to know, Paul.
So
every day.
Also, glad to hear that you're all downloading the app and turning your notifications on while we're here.
Thank you. Another question. Alethea, carry on.
I was just going to say, Joyce, I put in the chat my email. If you want to email me that document, I can try and attach it to the chat now while we're on the meeting.
Thank you.
Okay.
Oh, lovely. Thank you. Do we have any more questions? No? If not, I have been panicking a little bit because I was worried Mark wasn't going to join us, but I know he's here, aren't you, Mark? You are somewhere. You are here. So thank you so much for joining us. Over to you. Okay.
A few minutes early. What I'll do is I'll juggle technology and then I'll see what this does.
Yeah, we are a few minutes early, so we're doing all right for time.
Right, can you see that?
Yes, we can. Thank you, Mark.
Excellent. It's the benefits of PowerPoint Live. Just introduce myself. My name's Mark de Bernard Lane. I am head of digital programs for Southwest ADAS. So I, if you like, serve the directors of adult social services and local authorities, the 15 authorities, and try and assist them on their journey around digital, which is obviously, as you are aware today, is fast paced. Part of my role is around supporting data and cyber security, and I'm on the board for Better Security, Better Care, the program board, as part of that. And I liaise with Karen also as a local support organisation with the uptake of DSPT. So Karen invited me along today to talk about what good looks like in cybersecurity, but I suppose the issue with what good looks like, and I'll introduce this framework to you, is that it's got good data practice and cybersecurity woven throughout it, as well as it having a specific area, a safe practice. So what I thought I would do is walk you through this framework and just update you on what it is if you don't know what it is, who's using it, and where the direction of travel of this is. So is that okay? Is that all right? It's a nod. Great. Okay. I think few of us would argue that technology, when it's embedded seamlessly into care, can be transformative, and it improves people's quality of life and ensuring information is readily available to help staff deliver the right care in the right place at the right time. So I just want to admit that one. So it's important to note that what I'm about to show you is no one's making you do this. Currently, there's no expectation that you need to do this. Obviously, that's from a current standpoint. I can't second guess what the future actually might hold. But what good looks like is part of a suite of guidance which was developed by the NHS and Department of Health and Social Care, and it's structured around their 4 success measures under Transform, Digitalise and Connect. And they fall into the well-led, the smart foundations, safe practice, support workforce, improve care, healthy populations, and right at its centre, it's to empower people. And it is an aspirational framework. And it's designed to be used by local authorities and care providers, and each have their own, what I'll go through, their own statements, which within the success measures. And it isn't one size fits all because there are different roles and different capacities within all organisations. So it depends where you work. So let me just crack on with the next slide, if I can. So I found this, it came out a couple of years ago, and I found it a very important tool on supporting a digital journey for local authorities. And it had a section for care providers as well, which I thought would be equally useful. It is based on a self-assessment, so it is a very subjective view. And local authorities in the Southwest have been doing it, and they plan to do it again this year, so you can actually benchmark yourself and see where you are from where you've come from. So it's not to be a competitive exercise at all, it is a supportive exercise. And some of the evidence which is created and generated through working through the framework will be useful, and it will be useful in supporting other things like your CQC inspections. And it is being increasingly adopted across health and social care. So the ICSs completed their digital maturity using the What Good Look framework. Primary care completed their digital maturity using this framework in June. The results of those will be published shortly. The Southwest, 12 out of the 15 authorities undertook this benchmarking exercise, as I said, last year, and are due to start again this year. The Northwest and Northeast England, as far as ADAS regions, have already done that as well as part of the pilot, and more regions across the country, as far as local authorities, are doing it this year. Few providers have done this. Now, there are some exceptions. Norfolk and Waveney ICS did a pilot with their care providers, and it was very successful with a good turnout and good completion. So did Kent. So we can see there is probably a direction of travel with all of this. It's a very useful tool, and the more people who adopt it, I suppose the holy grail in this respect is that for the first time you'll be able to regionally and locally be able to see how we are across the health and social care system on the same kind of benchmark as far as digital maturity. So I think it could be quite a powerful tool for change. So what I'm going to do is I'm going to go through each of the success measures. I'm not going to read out all the slides. What I'll do is that I'll just sort of throw a bit of context around them, what it means. The slides will be available afterwards. Of course, some of the slides are a little bit wordy, but and therefore a bit small. So I hope you've got good eyesight. So the first one, and maybe arguably the most important, is having a well-led organisation and in digital. And what does that mean? It means your organisation's leaders fully understand the benefits of digital technology and have the confidence and capability to drive forward digital transformation and sharing learning and best practice. And having this clear vision and credible strategy for digital technology will ensure that this transformative power of technology, some of which we've been discussing today, is felt throughout the organisation. And this will obviously benefit those receiving care as you enhance the quality of care through the use of technologies and the better use of technology, and through that supporting the workforce in that. Now, leadership, management and governance of adult social care organisations play an important part in supporting digital innovation. I certainly find that when I'm working with local authorities, the linchpin, the tipping point is around digital leadership. And it plays an important part in both supporting the digital innovation and to understand the risks and effectively manage what is a large change. So by engaging with leaders, engaging with good practice, learning from others, sharing practice with the others across the sector, leaders can improve the understanding of digital technology and make the best use of it to invest in technology in future. And what I've done with this particular slide is just pulled out a few things in bold. In this case, quite a lot, but it's really about ensuring your staff and leadership positions have the knowledge and skills to deliver digital transformation. You have clear, or you've thought about investment plans to embed the use of technology. You have a continued understanding of the ongoing and developmental requirements in your care settings, because, as you know, technology doesn't stay still. So having a view of that and tapping into that, and drawing on accurate and timely data to understand your care needs and outcomes for your people, and ensuring that data is used safely and securely in pursuit of that. So, of course, with governance as well, as you know, with if you've completed the DSPT, is that and if you've got guardians in your organisation, we need to engage and inform people how their information is being used and treated. A good example of this would be around the advent of the use of AI and the issues around explaining to people how their information is going to be used and shared. Engaging with partners in your ICS leadership level enable you to tap into funding, to collaborate around certain things, and share bits of information about what's worked and what hasn't. So I think that falls into the statements within the success measure. So the second one is around ensuring smart foundations, and what does that mean? It means your organisation has. I'm sorry about the size of the text on the slide as well. When I put it in here, it was. I didn't really want to edit down each one of the statements, but this one is particularly wordy, so I do apologise. So it means for your organisation, you have a modern, secure digital infrastructure, and staff have a reliable access to comprehensive and up-to-date digital records, some of which you've been discussing today. Now, access to secure connectivity, the right technology, the right digital and data processes are fundamental to the use of digital solutions to improve outcomes. And so by considering these factors, including your size of your organisation, where you are, the demography, the capability you have in your organisation, you can ensure that your organisation is well equipped to provide positive outcomes for those people who draw upon care. And it also means that your information is securely communicated across health and care settings. Again, you've talked this today, and through secure email platforms in order to support joined up approaches to care. These are smart foundations. These enables care professionals to have critical information and connect with each other around, for instance, the shared care record or the digital social care record. So you have the right information in the right place at the right time. So that is fundamental, a foundation at the heart of supporting person-centered care. Safe practice. Now, this is the slide that I was going to initially focus on, then sort of realised that data and cybersecurity, as we already talked about, the responsibility around it in well-led and smart foundations already has that embedded in here. But essentially, it means good data security means organisations can safely use and share information, which ultimately can improve care and support of people. And as an organisation, you will take informed steps to protect people's health and care information against cyber threats and data breaches. Because as we know, in an increasingly interconnected, integrated system, my records, your records, our records, actually the person's records are moving between us and the system. And people's records are, as you talk with the NHS app, are an extension of the person themselves. And so we need to exhibit the same safety and respect for that data. So when you're actually using that data in the systems, you will be assured in what good looks like, that your suppliers of software and technology follow robust cybersecurity and data handling processes. And so you can ensure yourself and inspectors and various other people that it's handled in a safe way. And it also means that inevitably, you know, in living in an imperfect world, that there will be times where there will be risks to data breaches, but it's how you deal with those. You have the right processes in place in order to deal with that properly and alert the right regulator. And an extension of this, of course, under cybersecurity and cyber threat, that you have developed and tested it's right in your organization as a sort of a dummy situation, business continuity plans. So the next one around supporting workforce, and as we know, the workforce is the beating heart of our organisation, and having them well supported in terms of digital skills, having a capable and confident workforce which can identify, recommend, and use appropriate technology safely and effectively for people drawing on care. And in what good looks like, as an organisation, you embed a very clear vision for digital working and how you support your staff in all roles at all levels. And you can review and develop their skills, provide access to appropriate development opportunities. So that includes also you develop ways of working that focus on informing and raising awareness of digital technology. It's the myth busting around certain things. There's plenty of myth busting to be had around AI, for instance. Confidence building, that it's there to support them, support the decisions, support people. It's not to replace them, it's to help them spend more time doing the job that they're there to do, is to care for the person. And developing a learning culture. Staff need time to do this. And part of your leadership role is to ensure that with the avalanche of new technologies and new opportunities, new developments, that you have the awareness to understand what is important, how you can triage that and put that into your organization and help them decide or adopt particular evidence-led technologies. Otherwise, as I've found working with local authorities and social workers, the idea of selecting and recommending and prescribing technologies for people can be quite overwhelming because they've got a job to do, which is caring, which is assessing, which is reviewing. So supporting workforce is right at the centre of that. It goes without saying that improving care, what does that mean? Well, it's the effective use of digital technology, data and processes to support the delivery of outstanding quality and personalised care and support in the right place and the right time. I sound like the people at the Heart of Care white paper, don't I? But we should use digital technology to enhance the quality of social care and free up, as I said, this time for meaningful human interaction so people can create more of the heart-based care. So we know that there's knowledge-based stuff, and we're taught that. We got to do the physical side of care, but often that's recognised. But we need to free up time and value the heart-based care, the connection, the relationship, as you know. And technology is never going to replace that. But hopefully, with its efficiencies and productivity, improvements will enable freeing up of that. So within improving care, promoting learning culture, work with local authorities like the ones that I work with, and trying to understand the opportunities around maintaining people's independence, work in partnership with your ICS around quality and safety, reducing emissions to hospital, the kinds of devices and technologies in and around that, and be able to clearly understand what is in the market and articulate that. And once again, working through your partners, whether it's local authorities, whether it's the ICS, or whether it's your partners in your care association, it is sharing and understanding what the opportunities are around this, and making sure the choices you make as a business into those things, those investments, are ones which have some knowledge and experience of others in that as well to inform that decision. So so that sort of sharing and learning is right at the heart of improving care as well. So the next slide, which is the last slide. Now, healthy populations, it might not be something that you feel is within scope of your business. but a good picture of your client group, the client base within the population, and the emerging needs and the future needs of that population will be important for your business and its sustainability and its resilience. And understanding that data not only helps you respond to commissioners who are looking for new services in different areas or things like that, but also will help you understand, as I said, the changing needs of the people within your care and how you can deal with that. Now, digital is really important. The collecting of that data, the aggregating of that data, and the intelligent use of it to help inform your decisions of how you provide your services and things like that, so the care needs are met, so is incredibly important. So when we talk about healthy populations, it's not at a mega level. It can be at a very at your door, your client base level as well. But having the ability and the knowledge and the experience and the deliberate nature of using that data is important. Also, linking with research and evidence around these things. But if you are collecting data to look at measuring improved outcomes in your client base, you've got to understand the ethical considerations of using that data and their permissions as well. So you need to sort of express that. So I'm just going to draw to a close just a little bit. So 7 success measures, there's quite a lot there. It's over 50 statements, but they all provide really good handrails to guide your digital journey. And whilst it will end up being a self-assessment, the tool for itself doesn't exist at the moment for social care providers. It's there for ICSs and local authorities. And what is happening now, Skills for Care are working in partnership with Digital Care Hub and Partners in Care and Health to develop a couple of digital assessment tools. And one of them will be the digital assessment tool for self-assessment tool for what good looks like. They'll be informed by those other pilots which happen in other parts of the country, Norfolk and Waveney and Kent as well. I would hopefully like to see in that tool making sure we flag up the success measures and the statements within them which clearly support CQC inspection. So you can see that actually, if you were to prioritise things, you can collect the evidence in this area in order to support that dialogue. So they're holding a series of interactive, so getting involved in this, if you want to get involved in the design of it, is happening now. So over this month and next month, they're having a series of Zoom calls on looking at each element of what I've gone through and reflecting on each of the statements to design a tool for you to use in your self-assessment. The email digital@Skills for Care, if you want to drop them a line, see if you can participate in that. If not, there are still plenty of ways to inform that process, so you get a tool which is both benchmarked and aligns with the rest of us, but also is doable and usable for you. So drop them a line. As I said, this presentation will be available straight after the meeting. And I'm just going to draw that to a close, if that's okay. And if you've got any questions.
Thank you, Mark. I could listen to you for a long time.
Thank you.
Brilliant. That was brilliant. I can't see anything in the chat. Does anybody have any questions for Mark? Any hands raised? Can't see anybody. No. Okay. You've kind of qualified everything to do with digitalization and what we're doing. Lots of times people in this past couple of hours have spoken about the Data Security Protection Toolkit, which in the Southwest, in the areas that I support, a lot of people have embraced the toolkit. And in fact, we're kind of 81% of all organisations that are registered with CQC have completed the toolkit. And it underpins everything we've learned today. There's so many things coming down the road for helping us, for with digitalisation, and it's all geared up and designed to sort of deliver better care. Whether it's arguable, is some people the old way was better. Unfortunately, the old way, paper version, is way behind us, isn't it? So I can't see any questions. Has anybody got anything to ask Mark while he's here? We're very lucky to have had Mark's time this morning, so I do appreciate you giving us your time, Mark.
That's quite all right, and this is part of although that I do face towards the local authorities, and I've got my sort of personal view in terms of this is the whole system, and if we all sit in silos, so the NHS they cure their problems on their own, for instance, and various things like that. We all need to sort of, and we talk about person-centered care. We need to centre ourselves all around the person. We need to connect. So I'm only too delighted to come along and talk about this. As I said, this is something which is you're not officially mandated to do, but I'm going, this is a really good tool. I'm aware also that we spend our life ticking boxes and filling forms and having assessments left, right, and centre. So I'm really sensitive to the fact that this is could be just another thing, but I've used it with local authorities, and even if you just sit down with a cup of coffee and go through it and go, actually, some of these things would be quite useful to think about and reflect upon. If you go onto Google and do what good looks like social care, you'll go to the .gov website, which is there, and you can have a look through all the success measures and all the blurb. Actually, most of it is on the slides already. But just, I think for me, initially at this stage, it's a heads up. Think about this. It's a really good handrail. You can take a particular area, a selection of things, and say, I can nail these things, I can make these things, or I can talk to some of my colleagues and they might already have that. So for me, I've said to a local authority, oh, you're a bit weak in that area, you don't have evidence of that. Talk to that authority, they've got it. I'm not saying Control H, change your name on it, but what you're saying is that you've now got that document and you can say you're compliant. So what I'm saying is share and have a discussion around it. And even if you take a particular theme, you might be able to do something groupthink around a particular area to improve upon it. So, and I'm also here to help and support and ask some questions at any time.
That's brilliant, absolutely brilliant. And I'm sure everybody listening to you today is thinking, gosh, this, let's make it happen. We have done really, really well for time. But I on the end of the programme, I did tag on the Data Security Protection Toolkit. And I'm not going to take people through the toolkit itself, because I know a lot of people on the call today have already completed the toolkit. But clearly, it's an important tool. I've been supporting it for the last 3 years. But what I was going to do, I was going to share with everybody, because I think this is, if I can find it. What have I done with it? There is Digital Care Hub. Alicia, can you see this?
Yeah, it's coming up.
Yeah. Okay. So Mark's already alluded to Better Security, Better Care, and the programme that I have engaged with for the last couple of years, the Better Security, Better Care, have put together and designed a fantastic website called the Digital Care Hub website. And I know we've spoken about it before, but I just really wanted to sort of highlight to everybody what is available, what support and help is available, free of charge. It's totally there for everybody to use. There's a whole wealth of information to help you. So there is all of these boxes are links to lots of information sitting behind it. I always think of it as pages. So you open one, it's like a book, isn't it? You open one page and it leads to another. And there are behind all of these, there are lots and lots of links. Great bedtime reading probably, but there are things like templates of policies and resources that you can use. There are guidance. There's lots of information about what's happening. There's loads of webinars and recordings that you can use to train your staff. Because one of the questions I kind of ask most people is, so the person who's completing the toolkit will go through and understand the toolkit, but at what level do you share that with your staff? Where does that sit with, say, your deputies and your administrators? Data is so important, and as Mark's alluded to, there's a lot of data being shared between us for all different reasons, and how safe is that being shared is so important. I'm not going to scare you with facts of how many people are being attacked with cyber attacks, for example. Is happening, and it's happening to the smallest and it's happening to the largest organisations. So being prepared, Mark's already alluded to continuity planning. Have you included in your continuity plan data? How would you function if, because we've got digitalisation, because we rely on Wi-Fi, because we rely on our systems, how would you function if you couldn't access your system? These are the sort of things that the toolkit actually gets you to think about. So I'm not going to bore you with any more information. I'm just going to suggest that when you've got some, go onto this website, have a look at it, www.digitalcarehub.co.uk, and you can have a look around, and it's, as I say, it's free for you to use. And if anybody on here hasn't completed the toolkit, give me a call. I can help you. More than happy to. Okay, so that's me done. Does anybody have anything they wish to add before we stop sharing, stop recording, I should say? I don't think so. Is that okay? We'll stop the recording then, please, Alethea.